Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Get CME for this episode by clicking on the CME link in the show notes. Today in the show, we have George Tewfik. He's an anesthesiologist. His KevinMD article is titled Earning Trust in Anesthesia, How Recognizing Limitations Can Improve Patient Safety. George, welcome to the show.
Thank you so much for having me.
We'll get into the article in a little bit, but first off, just briefly share your story and journey to where you are today.
Sure. So I graduated from residency in anesthesiology at Rutgers, New Jersey Medical School in Newark in 2012. I went to private practice at St. Barnabas in Livingston for about 4 years, then joined another small outpatient private practice group for about a year. And then I've been back in academics for 6 years now at Rutgers in Newark. During that time, I've been really interested in education for residents and medical students, as well as quality and patient safety. So for the last 3 or 4 years, I've been in charge of quality assurance for the Department of Anesthesia at Rutgers in Newark, where we practice at University Hospital. In addition, I've been the head of the anesthesia simulation program and been leading their clinical informatics initiatives for our department as well.
Now, through an anesthesia lens, tell me about that transition from private practice back into academics.
Yeah, it was definitely a struggle. For anesthesia as a type A personality, you get very, concerned about the little aspects of our job, how you tape a tube, what medications you give, the timing of everything. So when you're in private practice, you're in charge of everything yourself. You do it all yourself. You see the patient from pre-op all the way through post-op. No one relieves you. There's no lunch breaks or, getting cases taken over by anyone else. So transitioning back to academics where you're supervising now 2, 3, sometimes 4 operating rooms, it takes a different degree of control and a different degree of trust in your clinician colleagues to be able to successfully navigate that transition. So it's definitely hard. And that's kind of where the impetus for the article came from. It's one of those things that, if people don't understand that transition and how important it is for resident education, then that transition can inhibit both your growth as an educator and the residents' growth in their education as well.
Now, for those anesthesia residents and considering job opportunities, you've been on both sides of the fence. What kind of questions should they ask themselves if they're to consider a private practice position versus an academic position?
Yeah, I mean, that's a great question. It really does come down a lot of times to, do you want to develop your own skills and be in charge of the patient, from pre-op to PACU yourself 100% and take on that responsibility? Or are you more interested in education, working in a collaborative team practice model where you work on ideas together, come up with anesthetic plans together, and really are collaborating on the patient care itself?
All right, let's talk about your KevinMD article titled Earning Trust in Anesthesia, How Recognizing Limitations Can Improve Patient Safety. Now, how did this article come together?
Yeah, so like I said, I've been in education now for 6 years, back in an academic center. I love it. Working with residents, working with a nurse anesthetist is fantastic. It just so happened that the impetus for the article was a couple of recent issues that I had. As the head of quality assurance for my department, I get all of the adverse events that are reported either through our staff or through the nursing staff or the hospital administration and go to review those. So I had several in a row where I really realized that if the resident had just asked a simple question, it stopped, to ask their attending faculty member something silly, a major problem could have been avoided. So it was kind of brewing in my mind. And then I had one adverse event that personally happened to me with the resident themselves. And it's not that I take it personally, but I was really surprised because the first thing that I tell the residents when I work with them in July, when they come on, is I will never be upset with you for calling me for something. I'll only be upset with you if you don't call me. There is no question that I will ever say, hey, why did you ask that question? I really prefer, even if it's something super silly that you're like, oh, a medical student should know this, I'll be more upset if you don't ask that and make a mistake than if you do ask that. It's never a bother to ask a question. And so many of these like little tiny things blow up into something big because something small wasn't asked. And that was really the impetus for writing the thing. It was trying to address both sides of it. As educators, we really should be creating that environment to make people okay with asking questions and not fearful. And for the residents to really understand that asking a question is not a sign of weakness. In actuality, it really shows a sign of wisdom that they don't recognize that they have a limitation there.
So when you further discuss this with the medical team and the residents, did you get some reasons as to why those residents didn't feel comfortable asking a question in a particular case, even when you gave all those assurances?
Yeah, it's a lot of times it really does come down to that fact that they don't realize that they don't know, or that they really are fearful because they're expected to know. By the time you get to your anesthesia residency, you were at the top of your class in high school, at the top of your class in college, you really excelled in medical school. You're getting here and you think a lot of times everyone's kind of looking at you. The nursing staff's looking at you, the surgeons, your attendings, your colleagues. When you're a resident, they throw a medical student in with you to teach sometimes, and I think there's a tremendous fear of feeling inadequate or feeling almost like an imposter syndrome if
Mhm.
you're standing there and you're supposed to be doing something and you don't know how to do it or have to take an extra second. In anesthesia, there's a lot of like snap decisions, really quick
Sure.
things that have to happen. So people get fearful about taking a minute to ask a question. I think it really does hinder patient care.
Now, what are some of the techniques that you use to establish trust with your residents? Especially, you'll be working with new residents pretty much every few months, every year. How do you establish trust with your residents?
That's a great question. It's really something I think that you've got to build very, very early on. Like I said, I have that conversation with the residents super early on when I tell them, Listen, reach out to me for anything. It's never a bother. Even if I've got a meeting or a conference call or something, administratively or a lecture or whatever, I tell them there is no question that I'll ever be upset. And I think you've got to build in that atmosphere of making them not feel inadequate or silly or anything for reaching out and saying, hey, thanks so much for reaching out about that. I'm really glad that you asked that before you gave this medication, or I'm really glad that you took the extra minute to really consider what this means for patient care before jumping to do something. So it really is about building trust between the faculty member and the resident. And I think it's something that's got to start from your first interaction with them when they show up in July.
Now, among your other attendings, do they have that similar emphasis in terms of asking questions? Because I think one of the reasons why residents and fellows sometimes are hesitant to ask questions because they don't uniformly have that supervisor who is so open, who has that open door policy. I'm sure they may have a negative experience when they previously asked questions to their prior attendings. So, what's it like among your other teaching attendings?
Yeah, so that's one of the things I struggle with. As the head of quality for the department, I really try to stress to the other faculty that playing that blame game all the time, especially like in M&M conferences and when we're reviewing adverse events, is never really something that should be looked as a disciplinary action or something that's a negative for the resident themselves. What we're really trying to do is to create a culture in which people feel open to bringing errors out and are not feeling shamed for asking a question or for making a mistake. That's not to excuse someone who's being careless or reckless, obviously, but if you create a culture overall that people are willing to bring their errors or their concerns out to the public, I think that that's something that overall improves patient safety. And there are several times where I've had to tell other faculty members, listen, take it easy. We're gonna present a case that's particularly troublesome or traumatic for the people who are involved. Like, don't attack the person, make them feel like that they are being shamed publicly in front of other people. It's really to create an educational atmosphere and one in which we could bring out problems to try to address something together as a department.
Now, what happens when residents and fellows make mistakes and you have to give feedback on those mistakes? How do you approach that situation?
Yeah, it's always tough. But people take it very personally. We have a lot of empathy, obviously, towards our patients, especially when you have something particularly catastrophic. It could really impact the person themselves. So I'm really mindful first and foremost of the second victim effect when someone has particularly something adverse that happens to one of their patients. So before we even get into the error, I try to tell them, hey, how are you feeling? Do you need to talk? We have mental health resources that are available if someone has something that they really need to work through. So I try to address that first before we get into the actual error itself, because I don't want someone to take it so bad that it
Mhm.
affects their other patient care. And then once we've cleared that, then I sit down and I start with the facts and have them lay down, exactly what happened step by step and have them work through it. And then we kind of get into debriefing each one. Sometimes we've got to bring in the faculty member as well. Sometimes we bring in their mentor advisor and the chief residents. It just depends on each situation. But I try to shift from, addressing their mental health and well-being first and then getting into the case itself.
Now, specific to anesthesiology, new residents, what are some typical blind spots that you see? Any trends or patterns that they need to be aware of?
Yeah, the first thing is really understanding when it is it time to call. Pretty much after the third or fourth week of an anesthesia residency, just by logistics alone, the anesthesia attending has to be able to leave the resident in the room by
Hmm.
themselves. That's nerve-wracking just as much for the faculty members as it is for the residents themselves once we leave the room. So at that point, the critical transition is understanding when it is important to call. And the first time you see a patient go from a heart rate of 80 to 110, that's a good enough reason to call and say, hey, what's going on here? And then you could work through a differential diagnosis of tachycardia or hypotension. And over time, you'll, as an anesthesia resident, you'll build confidence and be able to understand, hey, I've seen this before. I can work through the problem and understand what this physiologic derangement is, and then be able to successfully treat it. But making that transition to being able to understand what is something I can address on my own and what is something that I need another pair of eyes on, that's the critical issue in success in anesthesia.
Yeah, I agree with you. So that balance between fostering independence and knowing when to call for help. In general, how long does it take for a new anesthesiology resident to kind of develop that balance between independence and knowing when to ask for help?
Yeah, some people get it right away. You've always got a couple residents who text about, every single thing or call about every single thing. Like I said, that's totally fine. And then there are some who, hesitate a little bit. But generally speaking, within about a month or two,
Hmm.
for most of the time, the residents really do figure out what is something that is worth calling my attending's attention and what is something that I should be, at this point in my career, expected to understand. And it really has a lot to do with expectation setting on the part of the faculty, the chief residents, the senior residents. Everyone really needs to work in concert together and say, hey, at this point, you should be able to handle this problem. Oh, at this point, this problem is too big. You've got to call someone senior to be able to address that. So it really is a collective effort. It has to be on everyone's part to be able to help someone, especially when they're new, to try to figure that out.
We're talking to George Tewfik. He's an anesthesiologist. His KevinMD article is titled Earning Trust in Anesthesia, How Recognizing Limitations Can Improve Patient Safety. George, tell us some tips that you want to share with anesthesiology residents other than calling for help and having that open door. Any other tips that you could share with them?
Yeah, the big thing really for an anesthesia residency is to understand that you really are part of a team. A lot of times we get isolated. You look at your own case and you're in an operating room all day by yourself. A lot of times, especially if it's a long case, and it's hard not to feel isolated. But anesthesia really is a team sport. And the earlier that you recognize that as a new resident, the better that your progression as a student, as a trainee, and ultimately as a practicing anesthesiologist will be. We really cannot function by ourselves in a vacuum, even if you end up practicing in a small hospital, one day with a small group. Anesthesia really is a team sport. So you're interacting on a daily basis with the surgeons, the nurses, the hospital administrators, and then all the different consulting services that help to contribute to patient care, the medical physicians and the cardiologists and the pulmonologists. So in anesthesia, when you're starting out, a lot of times it's very easy to feel isolated. You don't see your co-residents or the chief residents or all the faculty at a single time. It's important not to feel isolated and recognize that you really are part of a big care team, and to understand that those interactions with those other care team members really can contribute very positively to our patient care, to patient safety, and to your mental well-being as a physician. It's very easy to feel isolated like that, but once you understand that the continuum of patient care really is very big and that you're one critically important but one cog in that wheel, it really does help to bolster your confidence and your understanding of where you fit in into the patient care team model.
And my final question, George, tell us some of your take-home messages that you want to leave with the KevinMD audience.
I really hope that people who read this article understand from both sides how difficult the transition can be to beginning someone's residency. As a faculty member, I get palpitations every time it gets close to July, because I'm like, when you finally get into a groove with the residents, you know which ones you've got to keep a close eye on, which ones you can give a little bit more of a leash and more independence to come, April, May of an academic year. And then as July comes, it's, here comes a new batch. For us with a 3-year residency, a third of our residents and trainees are going to show up. And now it's a whole reset. Now you've got to figure out all over again who is, trustworthy and going to be able to call in an emergency, who you've got to keep an extra close eye on. But recognizing on both sides of that transition is difficult, I think, is really important. We've got to understand that these residents are showing up, especially for anesthesia. Their last anesthesia rotation by the time July comes around was probably a year and a half ago in medical school. They just did a medical, internship or a surgical internship in which they spent their whole year on the floors doing scut work a lot of the times. So now that we're throwing them into this brand new environment where they don't know anything. And if our expectation setting is such that we think that they're going to be like one of the third-year residents who just graduated, that's setting up both sides for failure. So I think recognizing that transition is difficult on both sides. And then the residents have to understand too that as attending physicians, as faculty members, our responsibility is to that patient. They may physically be the one in the room or fear that they're the ones who are going to get yelled at if they make a mistake. But the responsibility really does come back to us. So we're trusting them with the patient care for the patients that we are taking care of in the operating room at any given time. And that trust, it really, does need to work both ways for us. So I think that really understanding the dynamics that are at work while we work in this patient care team model really will help both sides to set up for success.
George, thank you so much for sharing your time and insight. Thanks again for being on the show.
Thank you so much for having me.